excited today to kick off our programming around global health, and I'm excited to have this opportunity to bring these folks together to talk about how interoperability can be seen as a global good. Today, we're going to have the opportunity to be led through the concept of using OpenMRS, OpenHIE, the International Patient Summary, different IHE profiles to set up a health information exchange based on FHIR. We're going to talk about different aspects of potential interoperability global goods, including some of the content, like the different implementation guides and profiles, software, like the tech stack that I mentioned, as well as services like this Connect-a-thon event, IHE project-a-thons, and other interoperability events. So as we kick off this, I'd like to welcome our track leads for today. That's Derek Ritz and Jan Flowers. And I also want to thank all of our other participants who will be taking on other different speaking roles throughout the session. The concept of this is to be a launch pad for future activities. So we're looking forward to having folks join us in future events as well. Folks who want to interact with us have the opportunity to put in questions through the chat box, and we'll be looking forward to answering those as well. And towards the end of the session, we'll also point out some different activities that are coming up throughout the week that folks can participate in. And with that, I'd like to hand it off to Derek and Jan to kick off our global health track. Thank you.
Thanks, Amit. And thanks a lot for helping us set this up. I mean, this is something that is a long time coming. I would like to welcome everybody and thank everybody for showing up for this. When we talked about how to get this set up and how we wanted to begin, one of the things that as a planning group we wanted to do is point out, why this is different. And Jan and I had a discussion about this during that planning meeting, and we want to help people take the moment to give a bit of an emotional connection to what it is about this that makes a big difference. So my name is Derek Ritz. I'm starting off because Jan said, no, you start. So my colleague and teammate and one of my favorite people in the world, Jan Flowers, and I are the ones that were the track lead for this. And our job really is to get us kicked off on what I hope you guys are going to find to be truly cool. Jan, please introduce yourself in the long and distinguished lists of things that you're working on.
Thanks, Derek. It's quite complimentary. Yeah, I'm a faculty member of the University of Washington, and I see lots of names I know, which is really exciting, and then a lot of names that I don't know, which I'm excited to introduce some global health ideas to. Yeah, so I'm a faculty at UW, and I actually have 2 appointments there. I have my main appointment is in School of Nursing, where I've worked on a lot of US-based healthcare initiatives with a group that many of you might know, Bill Lober. He leads that group, and a large group of engineers where we do a lot of HIE work and have long interacted with IHE here. And then I also wear a hat over in the Department of Global Health, where the core of my work is, and really looking at how to apply those engineering principles in the real world global health context. And over there, I started a Global Health Informatics Center, which some of the folks today that you'll meet that do the demo and talk today work in that center. And really, we look at a few different things. We look at not just global health engineering of what we call these global goods, which is software that is for the public good, it's open source and available. But we also look at the context in which these things are applied. So understanding the policies and regulations needed to really support those software, understanding the capacity and how to build that in order that we can equip the ministries to actually take this on and own it themselves and be able to sustain it long term. And then looking at how you actually implement these things and making sure that they're well supported and serving the needs that are actually existing in that context. And so Aside from my university role, I'm also the chair of the board of directors of OpenMRS and on the OpenLS, which is the laboratory information system. I'm on the board of directors there. And then I founded the laboratory information systems community of practice under OpenHIE. And you're gonna be hearing a little bit today about OpenHIE from Jennifer Shivers.
Jen, why don't we, to catch up our time, let's just, please, can you lead us through these excellent slides that you've prepared? And to be honest, again, for all of our attendees, we actually want to give a sense of the very important role that digital health can play in some of the low resource environments that for the last decade or so I've been working in and that Jan's just described. Jan, these are terrific slides. If you'll lead us through these quickly, and then we'll get into the truly cool stuff that our colleagues are going to show in the rest of this presentation.
Yeah, absolutely. I just need to move something off my screen so I can see here. Give me just 1 minute. There we go. Yeah, so this is for those who don't work in global health. You know, Derek mentioned, why is this different? And global health is actually quite a bit different in the context that and the reason and the motivation for what we're doing. And so just to give a quick overview here, you know, in global health, we see just worldwide, not just in global health, in worldwide, 90% of deaths really do occur from disasters in low and middle income countries. And so global health countries that receive global health informatics support, they really are a disadvantage just from disasters that occur in the countries alone. And those deaths don't necessarily happen just from, you know, the disaster itself, but it also has to do with people being displaced internally in their country, people having to be highly transient because of those disasters or other reasons that happen in those countries. There's a lot of infrastructural challenges, as I'm sure you can imagine. Travel is very difficult with roads and bridges and you know, things that affect that, like flooding and earthquakes. There's power issues, telecommunications, although in some ways has leapfrogged the US, in other ways still is behind. There's access to clean water, food, sanitation. All these things really affect people in those countries. And in particular, the vulnerable populations, a lot of us actually work under PEPFAR, which is supporting HIV care and treatment. And so we really focus in on that particular vulnerable population. But in general, you can look at the disruptions to care that happen in global health are much more impactful than what we see here in the US or European countries. So for example, just simply access to care is more difficult. When there is a disaster or a disruption that occurs, it's even harder for folks like with chronic illnesses, like with HIV, to refill medications, to be adherent to their drugs, to get their lab testing results, to make sure that they're on the right care plan. You know, their paper medical records don't follow them around. They get lost, they get destroyed, they're damaged because of disasters. And then, of course, preventive services to really identify people who are newly infected. And we're seeing a lot of that in COVID. So everybody's getting really familiar with that. For some reason, my space bar is not working. So give me a second here. So in addition to those kind of natural disasters that are occurring, there's a lot of informatics challenges as well. And so because of some of those other like infrastructural challenges and things like that, we're seeing a lot of times what you see here is a picture of a paper records room for a medical record in a clinic. And so, you know, organization around paper records is lacking. A lot of times they're just overwhelmed with too many records and they don't have any place to put them. A lot of times this isn't kept in a safe space. So then, as you can see, they're piled up on the ground. So then they get destroyed by flooding. Alongside of that are these other aspects. So many times there's really just a small set of developers in these countries who really know how to do these things. It's a really complex environment with a lot of different implementing partners who have been funded to do certain aspects, and they kind of build in silo a lot of times these informatics systems. And so trying to get people not only the capacity to understand it, but connect them in a way to actually do the work so that the data doesn't stay in silos. And then there's access to training and education. Some of the testing and validation, people don't really know the understanding of the requirements that are needed. And so sometimes things are built not really in mind with what the requirements are and how to validate those. There's a lot of policy gaps and change management gaps. Technology often gets ahead of the legal and regulatory environment in these countries. And so then we have a pacing issue where technology doesn't actually include these best practices and standards. So you have to come in behind the scene and kind of insert those or bring things up to those standards. And then, of course, sustainability and maintainability, connectivity, infrastructure, environment, all those things come together.
Jan, just before you leave this slide, I had an opportunity, probably 10 years ago, to be on a panel with Mike Garon, who was a fairly influential person in the PEPFAR program. And he was lamenting on that in the previous, I think, 8 or 9 years, they had spent $100 million and no two systems that they had invested in connected to each other. And so this challenge that Jan is pointing out is one that we've been working very hard with the initiatives that she's part of and that I'm part of to try to address. And I'm glad you called out PEPFAR. They've been a strong supporter of some of these programs, as have other donors. But that's one that both Jan and I have benefited from PEPFAR sustained funding. Sorry, Jan, to interrupt.
No, please interrupt more. It's great. So today we're gonna be demoing a set of systems and the interoperability between them. And the work that we're showing has actually been work that was undertaken in a Haiti program. And so it was actually funded by CDC and then a few other groups like Digital Square and of course PEPFAR coming in together to figure out how to actually support Haiti and making these systems interoperable and making sure that their information can be passed around where it's needed and reused. And so I want to give a little background about Haiti itself so you understand the challenge there. It's a small country. It's about 11 million people. The life expectancy is fairly low there compared to a lot of other countries, and that has a lot to do with the natural disasters. We all know Haiti pretty well from the news, earthquakes, flooding, different diseases that crop up because of that. So their life expectancy isn't as long as it should be. And if you look at the Human Development Index of Haiti, it's really 169 out of 189. So they're pretty far down there for what they see as the different criteria of quality of life, which leads into that life expectancy, right? And so in the HIV public health system, it's really complicated. And if you look at the health system as a whole, they have 25 physicians for every 100,000 people. And in comparison, we can look here in the US, there's 280 physicians for every 100,000 people. So they're at quite a disadvantage just in capacity alone to treat people. They have 149 HIV clinics across the country. They have 41 different labs. Some of those are in the clinic and fairly small and will only do like a few, like a handful of different kinds of lab tests. And there's really only like 2 laboratories in the whole country that will do the full panel of tests that are needed a lot of times. And then there's, again, multiple funders and care and treatment partners all trying to kind of achieve their own goals and still try to figure out how to work together, which is really difficult. And then they have a 2% prevalence of HIV in their population, which is fairly high. I think they're ranked number like 10 or 11 in the world for prevalence. So a few years back, about 2 years ago, my team was brought in to really think about how to modernize their architecture. What they had before was built many years ago by a group of us that before we really had kind of a lot of these standards and guidelines in place, we built them an EMR that they use nationally across those 140, 150 clinics. And then they have a consolidated server. Now, it was pretty rudimentary, but it worked in that context. There's, again, problems with connectivity, there's challenges in capacity, there's difficulties in getting the hardware and the infrastructure. So it was very basic what we built, but it worked. And there were tried and true technologies, and there wasn't any like cutting edge things that we weren't sure were going to happen. But over the decade plus since, those technologies aged and the patterns became outdated. We learned things in informatics. We figured out how to do some of these things a lot better in the global health context. And a lot of the things we built had actually kind of bundled a lot of functions into the same monolithic set of tools. And so as they started to really try to scale these things, it just kind of fell apart and didn't really work. And so we came back to this, figuring out how can we modernize this with the standards and guidelines that we actually know work well in these contexts, and then address these particular key clinical challenges. So, loss to follow-up is a real problem in these places where somebody can just disappear out of the health system. And for HIV care, that means they're no longer getting their regimens, they're no longer adherent to their treatment, and now they're infectious to other people. And so lab results, people were having a really hard time getting timely and accurate lab results because the data would get lost, and then somebody wouldn't know how to make a decision for that patient in front of them. And then HIV regimens, it's really important for people to really know to follow a certain set of decisions around which regimens people should be on and when they actually go to the next set of regimens. And so without that data, they were having a difficult time figuring that out.
Just because I'm pretty sure you don't see chat, Jan, I'm just going to remind us that we're leading up to the next demo that we're going to see, and we're probably pressing for time a little bit.
Yes, I'm going. So today's demo, I just have a group of pictures here of the people who actually put together the technology side of today's demo. But I want to point out that this demo is actually a product of dozens of people that are not represented in those pictures. We're a community-driven group, and we really turn to these open source communities for support and best practices and guidance and then tooling. And so on the left-hand side there is a lot of the folks that were involved directly in the Haiti program itself to help figure out the context and help drive decisions and policy and get people moving forward on the Haiti side of this. And then on the right-hand side is all those open source communities that really got involved and committed to helping Haiti and really created significant contributions for this to come together. So to queue up the demo, we're going to talk about two different patients today. So imagine this patient comes into Quadabaquet, which is a facility, HIV facility there in Haiti. And she's 25 years old. She's got a couple of children, and she's really concerned about her health. She was recently diagnosed in her community. Community health workers often go out into the villages and actually, or the towns, and actually do rapid testing and diagnose people, and then refer them into a clinic. And so she was referred to the HIV clinic, and this is the first time that she's coming to that clinic. She also finds that she has to travel to other city to take care of her aging parents. And so she needs some way to make sure that she can have continuous care and regardless of where she's at. The second patient that we're going to talk about is Wanda Lasai, and she's a patient that comes into Foy St. Camille, which is also another HIV clinic there in Haiti. She's been receiving care for the last 5 years because she was diagnosed a while ago. But she's been receiving it at a different site. And there was some flooding in Haiti. Just imagine there's a disaster or there's problems in her city where she's at, and she's lost all her belongings. She doesn't have her paper records. She doesn't know what her medical number is, but she does know that she needs care, and she knew when she needed it. So she went to a new clinic to find out if she could get care. And so in the past, one of the things that has happened is when she has moved around or had problems, she's been shown in the program monitoring that she's dropped out of treatment. So, the health system there and the health government there has actually spent a lot of time doing what's called loss to follow-up, where they've gone out and searched for her to try to make sure that they can get her back into care. And then it turned out she actually was receiving care. She was just at a different HIV clinic. So, and with that, I'm going to hand you over to Peter, who's going to run our demo for us.
Hello, everyone. So my name is Peter Minkowski, and as Jen mentioned, I'm a developer at her group where we develop these solutions for global health systems. Let me just share my screen. For this demo, as Jen was mentioning, we're going to just focus on a couple of systems. So Isante Plus, which is the EMR that these patients would be using for their healthcare needs when they go to these clinics. Intermediary layer called OpenHIE, where that is able to coordinate the communications between these systems. A master patient index or a client registry that houses a consolidated record of all the systems and a shared health record that holds all the patients, a consolidated record of all the patients' shared health data. And we'll go into this a bit more in the white box demo or clear box demo, but for now, I just want to focus on the two patients that Jan mentioned. So in the first patient, I'll show how we would basically register the patient in one location and then import that patient in another location to demonstrate the client registry workflow that's related to a couple of ITI and other specs. And then in the second part, I'll show how we actually use an international patient summary to coordinate consolidated care across the across different instances of the EMR so that you can have a longitudinal record for each patient wherever they go. So let's start with registering a patient in a location. So if Margot Hayes goes into a clinic and is registered, and we just go through the registration very quickly, put in some things that are needed. The phone number. So we register this patient in one Isante Plus instance, and as that patient is registered, we have to send that data to the client registry so that we have a record nationally of that patient. So the client registry, you can see here that this patient now shows up in the client registry with their information uploaded. And now that we have this patient registered somewhere, we can go to another Isante Plus, another EMR instance at another location and try to import that patient and automatically link them in the client registry so that we know that these two instances of that patient in the two systems are linked, and we can share data across them. So if I go here and try to register Margot, if I put in her name, I see that it searches the client registry and shows that there's a matching patient found, and I can import this patient. And as the import goes on, you can see that the patient is imported with the information, the basic information that we put in at the other location. And if we reload this page, you can see that there are two records now matched for Margot, and one is from the instance in OpenMRS IHE Europe, and one is from this instance in Isante Plus. So now we are able to, across systems, have a record of that individual and link them to their instances in each different EMR, which is the first step to making sure that we have continuity of care, that we don't lose patients to follow up, all those issues that Jan mentioned. So now let's look at Wanda, the patient that has that already has a history and wants to be treated at a new location. So Wanda is a patient in this clinic, this IHE hospital, and she has a medical history in this clinic. You can see some vitals, some weight, etc. And we want to, again, import her and register her in a new location.
Can you hear me?
Yeah. Here, someone said something?
I think it was an accidental unmute.
Oh, okay. Sorry. Yeah, so if we want to register Wanda here, we again go through this process. You can see that we can import her. Oops, sorry. Maybe we can't right now. Well, I'll go to the other one where I already did this because it's a lot easier in the time that we have, and then we'll go through it a bit more. So Wanda Lasai was imported in this other location. And when she's imported, we can also go through and view this patient's medical history. So we can re-import this medical history. And you can see that in this medical history, you have a list of encounters, medication requests, problems, immunizations, etc., vitals from multiple locations that we can then give to the healthcare providers so that they can review the patient's history from wherever they got their healthcare from. And then if we want to, you can see that right now, Wanda has 2 allergies. If we want to update the medical history, we would just, for example, if we want to add a new allergy, we can add an allergy and we should be able to see this be updated in the shared health record and then updated in that continuity of care document that I showed as a new allergy, whatever Isante Plus instance we might be in. So we added this allergy here. So now let's go to our other Isante Plus instance. Let's go to the registration summary, re-import the continuity of care document, and you can see that there's a new allergy that shows up in the continuity of care document in this other instance. So yeah, that's a very quick demonstration of the workflows and a pretty quickly set up one. We will go into the communication and kind of pull back the covers a bit and see what the internal workings and of this communication are and how they relate to the standards and patterns that we want to keep pushing forward. But yeah, that's it for my first demo. So let me know if you have any questions.
So should we make the questions on the chat or talking here?
Yeah, I was just going to suggest, why don't we have the raise hand feature too, if people want to use that, because what's useful about that is it sort of sorts it for us so that we see who raised their hand first. There we go, and we have someone first out of the gate. Please, Edson.
Yeah, I just wanted to know, sorry for the background noise, but I wanted to know, like, I see this is a live demo. We have everything working over the internet. So what about the sites that have issues with connectivity? How this solution works? Thank you.
Go ahead, Peter. And others that have implementation experience where the internet is not always on. Just, yeah, I can tell you that's a very common thing. And just as a side note, I'm in Toronto and my internet went out this morning. So I'm running over my phone as a hotspot. So for low resource environments like Toronto, Peter, can we talk about what some of the challenges are that you've had to face?
Yeah, of course. And I think this is a huge part of trying to create an architecture for these environments. I mean, we need to have a plan in place for when connectivity goes down, that we don't just lose data, and that when connectivity goes back up, we actually are able to, again, synchronize the data that's required with the centralized servers. So the client registry or the shared health record or any other services that we'll talk about a bit more. In this case, the systems that we're using can rerun transactions that are failed, and also when the connectivity is not there, we don't lose anything, because when it comes back up, it loads all of the data that it missed. But that's something that I think is taken into account in some way by the current specifications, but that's one of the biggest challenges in global health. And I don't know if, I think it's just it's something that we've struggled and tried to address, and we're successful with, but it's not an ideal solution yet.
I noted that when Paul joined, he gave a shout out while Jan was doing her presentation. I just want to get it as a direct quote here. Global health informatics practitioners eat complexity for breakfast. And a go Jan. And the truth is we do have to design for these things. There are challenges being in a low resource environment, and we can't wish them away. So one of the things that I find makes even the simple things difficult is when you have to say, okay, and then what happens when you find that you're occasionally connected, and how do you design around the expectation of that, and have to be able to recover. One of the things that is very challenging about being in low resource environments is that all sorts of things that many of us don't think about in Canada, in the United States, in Europe, we have to be thought about. These are engineering constraints that have to be designed around by our global health practitioners.
And this is Amit. I just wanted to jump in and say we have a session scheduled on Thursday, which is open office hours with our ITI, IT infrastructure co-chair, John Murky. And this would be a fantastic discussion to have there. And that's what we want to do as part of this track. Like, tease out what are the issues and the gaps that we're missing. And not even missing, but how can we concentrate on those and make sure that we find those solutions going forward. So really appreciate the question, and also look forward to working on some solutions together.
We have another question from Kimanga, and you know what? Just in the interest of continuing to move us along, Kimanga, I'm going to let your question be the last one during this part of the Q&A, and then we're absolutely positive there are going to be more questions that arise, but please, the floor is yours.
Thanks, Derek. I really appreciate this. For me, I think this is an excellent initiative for continuity of care. I wanted to bring in another aspect, and this is the aspect of reporting. As we think about how this is going to be implemented, we also need to look at the possibility of double reporting, considering that some of this, like for example, if I use PEF as an example, it's site level reporting. So both of these sites will probably count this person as being part of their treatment, but reality is it's one person who got treatment. So it's something to consider even as we implement the shared health record. Thank you.
A fantastic point. And to be honest, I'm going to do two shout outs. One, please, Jennifer, when your turn comes up, can you talk a little bit about DASH? I'm not even going to give away what that stands for, but please, this is very much, Kimanga, something that is a challenge that is front and center, especially around PEPFAR reporting, as you've mentioned. The other thing, during the ClearBox demo, please, if I could invite some of our engineers to talk not only about what are the transactions that you're laying down in the databases that we're gonna see in the ClearBox demo, but also just if you wouldn't mind spending a couple of minutes talking about the data analytics initiative that I know you guys are involved in, and the fact that as we lay down some of these standards-based data, we're setting the table for a meal to have later, right? There's all of that helps us for the downstream analytics, and if you could turn your attention to that. I think I'm up next, and Amit, do you mind helping me? Just, I've got I think the current version shows that I'm supposed to do the job of being a bit of an on-ramp for what Jennifer's going to lead us through. Is that right?
I think we're ready for your cartoons, Derek.
My cartoons? Is it cartoon time?
It is.
So I know that not everybody on the call knows me, but those that do know me, I feel like I've reached the cartooning phase of my engineering career. So I'm going to, I believe I'm going to be sharing my screen. And if you guys all also believe I'm sharing my screen, then this is a victory of the first order. And let me just make sure it's going to show on the right one. Yes, it is. So, yep. Yes, full screen.
Yes, we can see.
All right. Terrific. So being not only getting on in years and reaching the engineering, sort of the cartooning phase of my engineering career, I'm also becoming lazier and lazier as I get older. So this is actually a reuse of slides that I prepared to introduce this session at the AHIN General Meeting conference that was held in January. And AHIN is an acronym for the Asia, oh, it's on the screen here, the Asia eHealth Information Network. And for some years, I've been involved in that absolutely wonderful peer learning network. And this was to just give a really short introduction. And I want this to be as short as possible because I'm kind of standing between you and a very great presentation you're going to hear from Jennifer Shivers. But I want to introduce the IHE profiles that are part of the FHIR version of OpenHIE. Jennifer's going to go into quite a bit of detail about OpenHIE, but a number of us on the call have been involved with that initiative right from its very beginning and have been helping it grow, watching it grow, seeing it take off. And I won't steal any of the thunder from her presentation, but it really is something that has grown into a very impactful and pervasive, to be honest, health informatics initiative on a global basis that speaks to these issues of interoperability and data sharing that Jan was introducing. So I'm going to go through this quickly. Firstly, this is a short plug for our hosts for IHE. IHE is in the interoperability business. The work product for IHE is to take underlying standards, typically a portfolio of underlying standards, and develop an implementable specification that can be conformance tested, that does operationalize interoperable data sharing. All of the work product of IHE is 100% global public goods. You can go onto the website, you can download every artifact there. So it fits very well with this this global public goods initiative and this notion that we want to develop things that are able to be leveraged in Toronto, in London, in Chicago, but are also available to help in Dar es Salaam, are able to help in Manila, are able to help in the places, some of the low resource environments where it can actually make a significant difference in improving care delivery, as Jan was outlining. Okay, let's talk about IHE's Firebase profiles, and in particular, there's two that I want to draw attention to. Amit had mentioned that John Murky has got a presentation coming up that we should look for, those of us that are attending the conference. The Mobile Health Document Sharing Profile, MHDS, is in fact an umbrella profile that has a number of others underneath it. John Murky was the primary author actually of this profile. And so shout out to John for the excellent work that he did. The other thing that I want to call to attention here is the International Patient Summary. And the IPS is actually an astoundingly well adopted specification. It was originally developed by the European Standards Organization, CEN. It's since been balloted by ISO. There are two implementable specifications balloted by HL7, a CDA-based version of the International Patient Summary, and a FHIR-based version, and it's the FHIR one that we want to draw attention to. Both the CDA and FHIR specifications from HL7 have been profiled by IHE. And that means we now have the ability to conformance test the IPS. There was also, in my view, a really important option that was introduced in the IHE profile. And that's, I don't remember what the exact name of it is, but it's a continuity of care option. And that takes the use cases for IPS and adds to those use cases continuity of care within a care delivery network, not just international patient summaries as they were originally conceived in Europe, when it was the idea that your data would follow you within the EU because of some of the mandates in that organization around being able to receive care, any European receiving care in any European country. All right, this is a diagram you're going to see again, but this is mapping some of MHDS to the OpenHIE architecture, and this is going to be introduced. I just want to, in my cartoon way, say that the MHDS as an umbrella specification calls out I'll just go by their acronyms. PMR applies to how you manage person-centric demographic information in a client registry. MHD discusses how you would manage shared health record information about a subject of care that would be in a shared health record repository. The MATIX profile talks about, we were just discussing reportable indicators, discusses how you would submit reportable indicators to a health management information service. MCDS talks about how you would support facility registry, health worker registry transactions, the management of those, and the interlinking of those, so that you can say which health worker works at which facility, providing what services under the auspices of which organization. It's a very powerful interlinking profile. The SVCM supports how in FHIR you would do terminology services. IUA talks about the authentication role, and then ATNA and CT talk about how you would keep things secure and lay down audit records for transactions that are traversing a health information exchange. We want to add to this information about the international patient summary. And as a FHIR specification, it's a FHIR document composition that has a number of parts to it. Some are mandatory, some are optional. And then these are all coded data. So again, the shout out around analytics, I don't like the metaphor of data mining. I think it's the wrong way to think of it, because it notionally assumes that if I have a big enough pile of dirt, there must be gold in there. I like data farming, the notion that you reap what you sow. And as we lay down standards-based data, we have the opportunity to reap what we sow and do analytics on these data afterwards. So this is just a bit of a shout out to some of the coding that's leveraged inside an IPS. ICD-11, SNOMED Global Patient Set, I think it's the global patient set, LOINC, and then ATC and DDD codes, which are for medications. In this AHIN short demo, I was introducing the idea that this meeting was going to happen at the IHE Connectathon, and that we were going to talk about patient registration and COVID-19 care and vaccination. Only, I mean, without calling me first or anything, there was a coup in Myanmar, and some of those use cases that we were going to be going through with some of our colleagues in Myanmar, for all kinds of reasons, that's a challenging thing for us to expect right now. Mercifully, we've got lots of use cases within the OpenHIE community, and we just saw an HIV use case. We might have the opportunity to look at some COVID-19 cases as possible explorations on this infrastructure later in the week and following. And again, I don't want to steal some of Amit's call to action comments, but put a pin in that. And that's all the cartoons I've got. I actually apologize that it didn't go quicker than it did, but my job now is to stop sharing and to introduce Jennifer Shivers, who's going to be going through this next. I thank you, Amit. The acronym, I didn't mean to descend us into Dante's 9 levels of acronym hell, but I know I did do that in the interests of time. Mercifully, Jennifer is a significantly better presenter than me, and will explain better than I ever could how some of that comes together in a more understandable way. Jennifer, please take us away.
Good morning, good afternoon. I hope you all can hear me.
Yes, we can.
All right, thanks so much for joining us. I am going to raise it up a little bit higher level than what Derek was at. Derek was kind of at the lower level. I'm going to raise it up to a little bit higher. What does OpenHIE do, and what is the OpenHIE architecture that much of this work is utilizing? And I think this has become pretty clear that OpenHIE supports patient care, population health, and healthcare administration for facilities workers and different things like that. But what I want to make sure that I'm highlighting is that OpenHIE is a community approach to architecture. And I also am going to be talking a little bit about this white part down here, which is that we do this in a way with standards-based solutions that are based on IHE. And I'll be digging into that just a little bit more at a higher level than Derek did. But to support patient care like was done in the demonstration. OpenHIE architecture provides many different capabilities, including patient identity management across systems, which is what was demonstrated. And so just a little bit about how do we put all these things together. Derek mentioned that IHE profiles are based on other standards, HL7, FHIR. I want to talk just a little bit about what's in that OpenHIE architecture specification. And I want to make sure that if Derek's point didn't come through clearly, that we're understanding that OpenHIE is based on IHE profiles and FHIR as well. So here's just an example of some of the profiles we use. Derek went through some other ones. This happens to be our alphabetical order list, and I'll be sharing these slides, but we do have a full list available if you're interested in looking at how we utilize those IHE standards. So kind of the way that OpenHIE operates, because we are a community approach, is that we develop the patterns, and we do that a lot with a lot of work partnering with IHE. So what we do is make sure if there's not a pattern that already exists, we work through the IHE process to develop that pattern. We then have different project teams and institutions that apply those patterns in unique contexts, like the Haiti example that we're talking about. Many of those contexts are in situations that Jan described in developing countries that have challenges that are different than some of the challenges we have here. And then what we want to do is make sure that that feedback from that project team or that implementation then informs the community, and then we can actually do the pattern again and make sure that we're updating our processes and using that feedback to fine-tune what we are recommending as architecture patterns. So just a little bit about what do I mean by those patterns? So I mentioned we're a community-based approach. So we have an OpenHIE architecture subcommunity that meets regularly. And then we also have other subcommunities that are focused on the individual OpenHIE components. And we create an architecture specification. And in that specification, there are three main things. One of them is the architecture diagram, one of them is component requirements, and one of them is those data exchanges that are built on top of the IHE profiles. So just an example, here's the architecture diagram that Derek showed. So this is one of the main patterns that we talk about, and this is meant to be a notional architecture, meaning that as it's implemented, it's possible that one system may serve as multiple components, or there could be multiple components of different types of systems as well. But this is meant to describe what the different components are. And I guess I'll just highlight them. The interoperability layer is the layer that we use to send information through. It acts as the doorway, or it focuses on making sure that we're handling security. And so some of the security profiles are also implemented in the interoperability layer. And then in general, what we had was a point of service application. So in the demo, you saw OpenMRS, which would be an example of an EMR. And then that was sharing information with the client registry, which is this registry of clients that goes across clinics. So it would be, this would be housed maybe at the Ministry of Health level or at a district level where patients from multiple clinics could be combined. So this is kind of the architecture diagram pattern. We also have minimal component requirements. So each one of those entities that's on the diagram, we talk about what are the minimal requirements to actually be able to support some of these data exchange patterns. So that's outlined in the specification. And the third thing that the specification outlines is really shows what these exchange patterns are and how those exchanges happen between the different components in OpenHIE. And so you heard Jan and Derek both referring to message specifications from IHE. So each one of these arrows would then be documenting exactly which one of the IHE standards is used to support this data exchange. So what I think I want to make sure that I leave you with is not only do we use community to develop these patterns based on IHE or in partnership with IHE, we apply them. And then one thing we're going to be working really hard on this year is making sure that as they are applied, that feedback then gets back into the community and then allows us to further update or develop those patterns as we document them in the OpenHIE architecture specification. So our community is ever evolving. This year, we've evolved a lot to support COVID. We've also been focusing newly on universal healthcare or health financing. We're working really hard to support supply chain interactions. Jan mentioned the laboratory community. So that's something new where we're specifying and working on how do we do those laboratory transactions. And then we also have a new community that's focused on education. So not only do we need to be able to do these types of transactions, but we need to be able to help people understand how to use these profiles and other tools to be successful in implementing and sustaining health information exchange. So I just mentioned these are some of the areas of the architecture diagram where we've had increased focus over the last couple of years. And so this is the place where we're seeing the most change. And as we work with FHIR and with IHE, we're looking at things like what does the developing world need to actually support a product catalog? Do we have everything we need to support the logistics transactions needed to make sure that supplies and medications and or vaccines are in the right place at the right time? So those are the types of things that we're working on addressing currently. We also have other tools to support implementers besides the architecture diagram, and these include a system that we're developing that helps get started with some of these components. We're working on documenting the stories about how these set of tools, like the demonstration that Jan and others are giving this morning, how are those tools impacting the world? We're also working on how do you get started using OpenHIE and the IHE profiles that are underneath it. And also, what is some of the training that needs to be out there in the world to be able to support these types of implementations? I will share this slide deck with you because it has how to join in with us, how to look at the architecture, where to join in meetings, and how to follow us. And so I will share that with you. And thank you for this brief opportunity to provide a small introduction to OpenHIE and how we leverage IHE and other standards to help us move forward in developing countries.
Wait, before you turn your mic off, would you mind just in the interest of the other question we had, could we just maybe have 60 or 90 seconds, Jennifer, on DASH, what DASH stands for, and what are some of the very promising things that that we're exploring with that? And maybe as it connects to the duck as well. And there you go. Mr. Acronym has just introduced two acronyms that Jennifer is going to have to lead us through.
Yeah, so as we look at this picture, I think one of the things that's missing is some things about how do we go from like patient level, patient level metrics that are collected here at the point of service to actually being able to store metrics in an HMIS like DHIS2. So how do we convert from this patient level to DHIS2? And so DASH is, oh gosh, Derek, maybe you should remind everyone in the chat what the acronym stands for, but it's basically an analytics engine or process for taking data from a system like OpenMRS, then sending it to the interoperability layer. And we're putting an engine in this interoperability layer that's allowing us to use some of the IHE standards and also FHIR standards to be able to calculate those metrics. And then we use the ADX or MADX profile to send that to the HMIS. And so it's a method we're working on for, in a standard way, being able to calculate those metrics that are stored at an HMIS level from the patient data. And so maybe those of you who aren't familiar with an HMIS, it's basically a system that collects and stores health system metrics. So a typical metric for HIV might be how many people are on antiviral care. And one of the problems that was discussed as we were looking through the demo and by Derek and others is that if you're actually collecting data from 2 different clinics and the same patient has gone to the to different clinics, you might actually double count that patient if you don't have a client registry. So DASH is the analytics process that we're using to calculate using the client registry and making sure we're deduplicating those patients up front to make sure that we are not counting duplicates. So this is a project that's being worked on by PEPFAR, which Derek shared what that acronym means. It's in the proof of concept stages. So right now, I know that there's a proof of concept going on to describe how we can use IHE profiles and the underlying FHIR specifications to do those calculations and transmit to a health metric system. And then there's also proof of concept going to get OpenMRS, which is an example of an electronic medical record, how we can get those individual patients and send that data to an engine like DASH in a standard format, and then be able to do that calculation. So the proof of concepts are happening. Not everything's put together yet. So we look forward to figuring out and working through how to put those things together. I think those pieces are coming along nicely, and I wouldn't be surprised if we hear more communications about that in the next several months.
I actually tried to describe DASH and I got the acronym wrong, but James Karaoke fixed it for us. So it's the Data Aggregation Service for Health. And that's DASH. And as Jennifer says, it's the ability to take the granular content. If we have granular content, person-centric content, it is a way for us to more smartly use that to avoid some of the double counting or erroneous loss to follow-up or some of those challenges that that plague us on the program management side. And thanks, and sorry to put you on the spot like that after you got to the end of your presentation. Jennifer,
Yes.
that was wonderful.
Thanks for reminding me.
So I think, you know what? I think I'm going to hand off to Jan. And Jan, can you set up the team for our ClearBox demo?
Absolutely. Yeah. So now that you have the lay of the land, we'll come back to our demo and just reminding you of our patient journeys from the first demo where we talked about, I think it was Margot, who's the new patient. I might have these backwards. Margot, who's the new patient who came in, and we registered her for the first time to receive HIV care at the clinic. And then, gosh, I can't remember the other woman's name now. Sorry about that. Wanda. It was Wanda who actually had been receiving care and then is moving around and needing her shared health record and her longitudinal record to be transferred to the sites that she's seen. And just to give everyone a little bit more flavor about this, this is not true with every country, but in Haiti in particular, there is no concept around transition of care. So it's not, or transfer of care. So it's not like you have a home clinic and that you always get seen there. They really can show up at whatever clinic they want. And so with that in mind, I think Ian and Peter are going to take us through a demo that you get to see a little bit of the underworkings of how this all comes together. And just to also call out a couple of other folks that have joined us that really, one who leads the software engineering work in Haiti, Kimar Celestine. I hope it's okay to call you out. He just joined us, and so he might have comments here. I'm not sure when they're going through the demo. And then Christina White, who's leading the work on the UW Digi side, supporting Kimar and his team in Haiti. So you two feel free to speak up if you want to add any flavor to the demo as we go through it. Ian, Peter?
I just also want to make a call out. Turn your cameras on. I see Ian has his on. Peter, turn your camera on during the demo. And just as a time check, it looks like we're sort of 15, 20 minutes. Does that sound about right for the Clearbox part?
I think so, yeah.
All right, we have a bit of time to go over if you need to. Please, guys, take it away.
Peter, you're on mute.
Yeah. Yeah, so feel free to jump in whenever you'd like. For example, if I'm on mute and you need to unmute me. But yeah, I was thinking of starting with just the OpenHIE architecture that Jennifer shared. And like she mentioned, we're focusing for the work currently on the client registry, the shared health record, this interoperability layer, and an electronic medical record for what we're looking at. And I think, Ian, it might be good just to talk a bit about each system and the tech stack that is behind them. Do you want to start with, since you're the OpenMRS expert, just go over the electronic medical record and OpenMRS and just give an introduction to that system?
Sure. I think though first I'm going to start out with a small call out to Happy Fire, without whom I don't think any of this tech stack would exist, because we essentially have a Happy Fire instance running in OpenMRS connecting to a Happy Fire instance covering OpenCR. It's Happy Fire all the way down. But OpenMRS, for those of you who aren't familiar with it, is a modular platform for building medical record systems. If that, and I think that's the best description I can come up with for it. And it's used a lot in low resource settings because it has a lot of flexibility. We try to provide a lot of flexibility in how you can use it, how you can customize it. The eSante Plus version that you see here is really quite cool and nifty, and using some of the more cutting edge things, particularly the Fire module, that the Fire 2 module that I kind of serve as the lead developer for. And so yeah, it's through the magic of this module that gives us these big JSON nonsense that we're able to connect OpenMRS into this broader sort of architecture that's laid out by OpenHIE, IHE, and all of that. And I'm just going to put out a specific call out that we're always looking for new opportunities to build new kinds of connectivities and meet implementers' real world needs where we can. So this is the really exciting part of this, is seeing work that we've done for over a year now actually turn into something very real.
Well, yeah, semi-real, since it's still in the pilot stage, and it will be even more exciting when it actually but yeah, no, that was a great intro. And as you can see in our demo, we're using 3 OpenMRS instances that are running the eSante Plus flavor of OpenMRS. The next really important system that we alluded to a lot is the OpenHIM intermediary layer. And that's basically in this diagram, let me just go back. That's the interoperability. That's a application that implements this interoperability layer. And it's an application that runs on a MongoDB database, and it's, I think, a Node.js application that has a user-facing console part of it, which we can see right here. And basically what OpenHIM allows you to do is take all of these communication patterns and organize them and have auditing, have logging, have authorization, authentication capabilities. So for this setup, we are basically using the two mediators for the two parts. I won't go into details too much, but these mediators define a couple different channels which get used by the transactions to correctly route the transactions as they come in. So we have one entry point for all the transactions, and then based on the channel URL pattern and other things, we can route them to different endpoints. And this whole transaction log, you can see in the console, oops, sorry, my bad, provides you with a pretty in-depth view of each request that gets sent. And you can see this history that we're looking at here is from the requests that were sent to for that demo that we were doing a bit earlier. And they're basically communication patterns that that use the fire resources, fire patient resources. Oh, maybe if I can find one. Rose, sorry. I'll find one, for example, this one. This is a request that was sent when we created an allergy allergy, like when we added an allergy for one of the patients. And as soon as that allergy was added, it synced with an upstream service, the SHR, that specific resource. So that's one example of a transaction. There's also transactions here that involve the MPI workflow. So for example, this transaction that is get patients, this transaction gets sent whenever we search a patient, it gets sent to the MPI. So it gets sent to OpenHIM, routed to the MPI or the client registry. And the client registry returns the patients that match this given search. And then we use it in our workflows. So OpenHIM is crucial. Yeah, go ahead.
Oh, I was just going to say, so for that search, if you remember when we were typing, when we were registering those patients, there was a little pop-up that came up that said, you know, oh, we found this matching patient. That's how that's implemented on the back end. We send this query, right. This query that goes across and comes back, but it actually works pretty speedily.
Yeah. So for example, here when you search WAN in the first name column, it immediately sends out a search and gets a response with 3 possible patients that are matched by the client registry service. Okay, so that's OpenHIM. So the next 2 systems that I want to talk about are the client registry and the shared health record. And maybe I'll get to this in a bit, but basically the client registry, it does have a user-facing interface. The shared health record is built in a very similar pattern as the client registry, but they are both Node.js or Express.js applications that for their data store actually use, as Ian mentioned before, the all-powerful HappyFire JPA server. So, I mean, the reason the HappyFire server is so useful for this work is because it provides, we should link out to it a bit, but it provides an implementation of the Fire spec that is very close to the actual specification. It's the reference reference implementation, and it's freely available to use. So it's a very good stand-in if you need a fully functional Fire server as a data store. And we can see that these Fire first tools actually utilize the HappyFire server sort of as their database. They don't have any other, like there's no additional database. All of the data that supports the functionality of the client registry and the shared health record is stored in HappyFire. The Open Client Registry also uses Elasticsearch to facilitate matching patients and the different algorithms that they provide for matching patients. Since the Fire spec itself does not yet have as powerful matching and searching capabilities so yeah, so those are the systems. I'm going to just pause for a brief second and see if anyone has any questions, because that was a pretty quick overview. And yeah.
Could we, again, use hands, please, if you want to ask a question so we can tell the order that they come in. And yes, it was a bit quick, but one of the things we very much wanted you guys to see is that, you know, there's nothing up anybody's sleeves here. This is infrastructure that works. And just because I happen to have an open mic, I'm going to do a shout out to the engineers that make sure it works. And Ian and Peter and guys in your team, thanks so much, because just so everybody appreciates it, there is a working OpenHIE reference infrastructure that's been set up on a virtual machine so that we could do these demos. These were not canned demos. These were real demos. This is stuff that's working. And it, in fact, is going to be a wonderful global public good in its own right that we get to leave that up. And again, that's a bit of a setup for some of the stuff that Amit is going to get a chance to do later when he talks about how we move forward with the vision a little bit. Please, are there questions? You guys are amazing.
Yes.
That was a description for the ages, because there are no questions. Oh, Richard Stanley.
No.
There you go. Thanks, Richard. Please, the floor is yours. And please, you're such a handsome fellow. Turn on your camera.
You're very kind. I'm not at my video desk, so you probably wouldn't see me since it's so dark in here. So I think, first of all, what a wonderful, wonderful session. And that's not just because I absolutely love working with OpenHIE and the support and mentorship and everything, and you know, that comes along with that. And there is that. So I certainly encourage others to join us and drop in for calls that interest you. Sign up, and maybe not all of them will be interesting, but many of them will be. And to share your expertise, build capacity in low and middle income countries to move the population needle and improve public health, so people live longer, healthier, and fuller lives around the world. Benefit from your knowledge. But one thing I wanted to highlight is that there is an effort going on in OpenHIE to, you know, with support from some investors like Path and Digital Square, to create a simple, easy to use health information system in a box for things like demos and testing, and to help folks understand what they need for production before they put it in production. So let's say you want to test these workflows and you want to say, okay, I'm going to push data from here to here to here, and look at an indicator, for example, or measure a report, or push that data into a machine learning system, or push that data into Power BI, or however you want to do it. Or maybe just something simple like, hey, I want to just assign a patient an ID, right? Which isn't simple, but something along those lines. So we're taking all of the wonderful Docker files that people create, and those images, right, that are out there, and for OpenMRS or for the client registry, for OpenHIM, and we're really open to anything, right? And bringing those into a platform to just kind of launch them, and it's really meant to be simple. So you use existing Docker images, and we bring those into Kubernetes or into Docker. People can launch Docker on their computer, and then we help with config. And you can write the configuration stuff in any language you feel like. You can write tests, and those tests can be in any language you feel like. We're encouraging folks to use Gherkin to describe the tests, but the actual runtime language and all that for the test can be in anything. And this project is called Instant OpenHIE.
I was looking because the name says it all, and Jennifer couldn't wait. She actually put it in the chat.
Yeah. So
it's called Instant OpenHIE. Perfect.
Yeah, maybe it should be called Instant HIE. What I'd love is for all the folks in the IHE community to be aligned with those folks and with you folks, and figure out how to do a lot of that, especially the workflow testing and things, in a way that's shared, so that there's no duplication of effort. So that's
Richard,
another area of excitement. And that's it. Sorry.
Thank you. Well, no, thank you also for doing the shout out and the invitation for everybody to join the community. One of the truths about OpenHIE is it is an artifact set, but it is also a very active community, and there's that to like about it. Do we have other hands up? I see Richard, yours is still up, but okay. Well, you guys are going to get the gold sticker for the best Clearbox demo ever. Got to roll the R on ever, because because it was so clear nobody had questions.
Well, I think one of the great parts of the conversation that Richard just mentioned is, yeah, we actually have been looking at instant OpenHIE because the goals of that project are very similar to the goals that we had. And you can see that the target transactions that I'm putting up here, I didn't know about these standards, and possibly they didn't exist when we were designing this even a couple months ago. And if we did have a more mature framework for how to design these systems, if we did have a more mature, for example, instant OpenHIE or any other specifications that we're talking about here, it would have really cut down even our development time, our time to figure out where we have to go, what technologies to use. Kind of, we had to do a lot of the work that would be already done by an instant OpenHIE, or that would already be done by these more mature profiles that actually have a reference implementation that can be quickly stood up and demoed. It would have immensely, it would have cut probably our timelines at least by half.
Peter,
so I think this just highlights the importance of this type of these standards and work.
It's like having a shill in the audience. You know, we've never met before, have we, ma'am? But you managed to just you managed to do a perfect segue to the next portion of our festivities, which is to talk a little bit about vision. And this is where, there he is. He's turned his camera on. This is where Amit and I get to do this, and I actually would just love to set the table for Amit. And please, and I keep looking. Sorry, I've got on another screen. I've got our run of the meeting. Are we on track? Or are we going to have to start going like deputy dog to catch up? How are we, Amit?
I think we actually should shorten just slightly what Jen and Grace are going to talk about, and then what you guys are going to talk about as well.
Oh, I jumped one.
Yeah.
Sorry about that.
Yeah. I also want to I did want to make a quick comment based on what Peter had just said. Is that okay, Derek? I'm just going to take more time. How about that? So I just want to make the comment when Peter's talking about like cutting our time down. One of the things that people don't work in global health don't always realize is that the funding resources are so much less in global health than they are in US based and Canada and European based care, that it's not the same amount of time that you have available to do these kinds of things. And so like, you know, where a US based project would be, you know, in the hundreds of millions of dollars from even a single hospital like UW Medicine, where I used to work, you know, they spent $70 million just to get an implementation up and running, right? You know, that's like 10 years worth of funding or 15 years worth of funding for one of these countries to do their entire national system. And so like you're talking about trying to really figure out how to be more efficient with this and how to do things better in a quicker and shorter timeline. That's part of the reason this is extremely important to come together and do these things in a way that can be replicable quickly across different countries.
As handsome as he is, we're not going to see Amit go next, please. And I abjectly apologize to Grace and Jen. You're on.
No worries. Let me just share my screen and then we'll get going. We're going to try and make this pretty short and quick, but we do want to start thinking about what impact we can make. And through this first half of the session, I was thinking concurrently about you know, what were some of the challenges that the group encountered, and what were we as a community, as the OpenMRS community, doing at the same time in regard to testing and making sure that these solutions, these interoperable solutions, are high quality and can be trusted. So I just want to really quickly highlight 3 key challenges that I think will resonate with everybody, and then look very quickly at what we as a community did in terms of testing during the same period, and then turn it over to Grace to talk a little bit about our community experience and then where we could go from here in the short term. So first of all, the challenge is we have to keep in mind that in a single country, improving high quality care to patients who are moving between services and facilities and networks requires information to flow across multiple systems. And what we're trying to do is create solutions that work for multiple countries and have some degree of flexibility. And the Haiti example in particular, I think, really demonstrates how making these systems interoperability relies not only on collaboration among stakeholders at the country level, but internationally. And this is something that we see, just within the OpenMRS community, but taking it further and including other communities and other global goods kind of makes this collaboration supersized and even more critical to keep in mind as we think about assuring the quality of these solutions. So yes, these systems must be high quality, sustainable, and at the same time respond to a country's context and what's going on in terms of implementation. So the testing piece of it, I think, needs to keep in mind the same challenges that the team encountered as they were developing the solutions. We're dealing with multiple stakeholders and partners. We're trying to figure out where there can be community alignment, right? Right now, we have it around Gherkin definitions, but there's this tension between giving people the flexibility to use a particular language or engine for test scripts. How do we figure out data test sets? We're trying to figure out where there's flexibility to create generalizable solutions and where does that boundary exist. So pretty much how do we work in the same direction and promote reuse? And this is very similar to the question that our OpenMRS community QA support team was grappling with, not only for our own community QA processes, but keeping in mind the fact that what we are building as a community needs to be interoperable with other systems. So just to highlight quickly, we really did we're community driven. So we really want to make sure that what we do around quality assurance and testing across the board is community sustained. So this meant looking at how we provide support and guidance to the OpenMRS community, to implementers, OpenMRS implementers in our ecosystem. And then in this context that we're talking about, how we can collaborate with other global goods, with OpenHIE, with countries, to apply the QA tools and processes that we might use as a community to interoperability use cases, and sharing the lessons that we've learned on implementing our community sustained QA processes. So I'm going to hand it on to Grace to talk a little bit more about that, and then where we might go from here, at least in the short terms, what we might focus our attention on in terms of projects.
Thanks, Jen. Over to the next slide. So I'm the director of product at OpenMRS. My background is nursing, informatics, and product management. And we're really entering a new era in OpenMRS quality assurance. We've had this culture shift that's been going on for the last year, where we've really come together and said automation needs to be a top priority for us as a community. As may have been mentioned before, unlike a typical EMR vendor or a SaaS organization, we don't have a large core team of developers or engineers or quality assurance engineers. And so in addition to that, the organizations that use OpenMRS and contribute typically are facing, as Jen mentioned, extremely tight deadlines, tight budgets, limited resources. And yet, amazingly, these organizations join OpenMRS and contribute their time and team members. We also have many volunteers around the globe, quite literally, who are regularly contributing to our open source project. So when we do releases, they need to be a couple of things. Number one, they need to be trustworthy for a couple obvious reasons when you're an EMR, but also because our end users are often so crunched for time that there's some trust there about the kind of quality assurance that's going on with our system. And we also need the releases to be often enough that contributors' work is being used, and you can see the value of what you're contributing to our community. We also can't count during a release on something like a sizable QA team that a SaaS company might have who's doing copious manual testing, for example. And when you're a contributor or a volunteer for an open source group, you want the work you're doing to be exciting, and copious manual test structures aren't really that exciting. So we've been working hard to try to figure out how do we set up a good QA framework so that we're not having to redo manual tests multiple times before a given release, and so that there's more reassurance broadly. So next up, Jen. So we've been looking for the last year at something called Cucumber in a couple different ways, how it can help us set up BDD tests, run those tests, and then report on those tests. There's a couple advantages to this. It increases visibility of the end-to-end process. It gives us a clear framework and a thoughtful structure that we've been setting up over the last year. And it gives us a collaborative tool that we can point quite a wide variety of contributors to. It also allows us to support integration with multiple test automation frameworks. So for example, we do a lot of front-end related testing, obviously not so much for interoperability conformance, but as far as the product goes, this allows us to support additional things like Selenium and Cypress, just as an example. And disadvantages, it does add a layer of complexity. We've had to be very thoughtful, structured, and strategic with how we set up the Cucumber framework in our QA framework. And finally, it does require changes to our current processes and how we use our resources. So we have a QA support team that's community-led and community-run. And at the moment, we're doing a lot of training and capacity building and teamwork in that QA support team. Next slide. So in terms of the testing vision, we are really excited to collaborate further with OpenHIE on what this is going to look like together, because as Jen mentioned earlier, we've got the need for data exchange between components, and also to check have we met the component requirements set out by groups like OpenHIE. How are we actually going to do this? Well, we'd love to be part of creating a test toolkit that's modifiable to local needs as a global good. And as others have mentioned, a global good is this thing that's been is a vetted open source tooling that's been proven to work at scale. So we're looking at trying to be an example to the broader HIE community of what it might look like to have Gherkin written test cases in a shared repo, and what those processes, tools, framework, test data creation might look like as shared assets. Next slide. So what can we move forward with? What could we collaborate on this week? There are a couple ideas that came to mind for our team, and I'll allow others to dig into this in some more detail, but these are things like regional extensions for the IHE profiles for Haiti. Conformance testing is obviously a big one, as I mentioned, and implementation guides for immunization, diabetes, HIV, TB, malaria. And finally, a topic that's probably on everyone's mind these days, a smart vaccination certificate. Next slide. So there's a couple sessions that you might be particularly interested in checking out this week at the IHE Connectathon that are mentioned here on Wednesday, Thursday, and Friday for the next 3 days. And then also, if you're interested in any of these particular topics, you are welcome to join our teams, join our community and our amazing contributors from around the globe. We've got a squad that meets once a week to work specifically on integrating FHIR, both for interoperability and data management practices. We've also got a QA support team that's also meeting weekly and crunching through what it means to actively use these automated frameworks. And finally, there's a OpenHIE DevOps subcommunity that meets once a month, and it has an open door for people who are interested in learning more about this and contributing. Thanks so much, Jen.
Yeah, and I think the DevOps subcommunity is where a lot of the questions around testing is intended to happen, and it's coming up more and more frequently. So just a shout out to that.
Thanks, Grace and Jen. So I hope that everybody's, I mean, some of this stuff is starting to get threaded together a little bit as we go through the different parts of this session and understanding kind of how this is all coming together. And even though there's lots of activities happening across the environment and across the domain, you can see where there's some convergence around kind of creating a set of tooling, a set of standards that are used for that tooling, and then understanding those information flows and how we actually test those. And so with that, I want to hand back over to Derek and Amit to talk a little bit more about IHE and the vision and where we're going with all of this, and why is IHE even doing this? Why is this important for IHE, and kind of the opportunities they see for the next steps.
Well, all right. With that, I will try to take that baton and move it forward. But really, it comes down to the folks that are all on this call and that participate in this session. I think it starts by getting some of these like-minded folks with a common vision, mission, goal together. And so thank you for that. But as far as the vision behind this track, last year at the Connect-a-thon in January, we were planning to make the event bigger and more exciting in 2021. We thought, let's move from Cleveland to Atlanta, so it's a little bit warmer. We're a little bit closer to our friends at the CDC, and we're gonna really just focus on public health and global health. And that was before the pandemic. And so we were fortunate enough to have our event in January last year, and I think that let us really gave us the opportunity to put this event on. But the pandemic disrupted business as usual. It laid bare some of the obvious and not so obvious faults in health systems all over the world. And so I think many of you share this feeling too. For those of us in health IT and health informatics, now is our time. If we can't make something happen now, we might as well hang it up. And we've heard throughout this call that resources are limited, and the scale of resources may differ, but the limitations are true, and they happen everywhere: time, money, expertise. But these resources are being spent and exhausted. And so, can we do better? I think we can. And so, if you've had an opportunity so far to view some of the sessions that we've put on demand so far, Joyce Densmeyer, the IHE USA president, Graham Grieve, who most of you know, Dr. Walter Suarez, the board chair of HL7, and others, we've mentioned that healthcare is global. So I feel we have an opportunity now through FHIR and because of the challenge of a global pandemic to harness some of this passion and energy and hopefully drive some change. And so this event was managed by IHE USA, but we're part of a bigger global organization, that's IHE International. And we're sponsored by even bigger organizations like HIMSS and RSNA. And together with HL7 International, we formed this global consortium for e-health interoperability. And simply put, the goal was to elevate the conversation around interoperability, so we can improve the alignment of resources for interoperability as a global good for everyone. And so our vision for this global health track is to support the development of interoperability global goods at scale. This was able to happen, as I mentioned, with support from HL7, IHE, and the Global Consortium for eHealth Interoperability. And between these three organizations, HL7, HIMSS, and IHE, we're probably responsible for 80% of the meetings that happen in the world. And I said, resources are limited. We can't attend every meeting, work group meeting, connect-a-thon, et cetera. But I think we have an opportunity to do more together and in a complementary fashion. And you're going to start seeing that going forward from today. I believe we together can provide a hub for the broader communities of implementers across the world. And so one practical way is by driving continuity between the Connect-a-thon events. And so you're going to see a global health track at the FHIR Connect-a-thons in May. You're going to see it in the European Connect-a-thon in June and other Connect-a-thons after that. We'll also be trying to tie these testing events with knowledge events to keep the cycle moving and to create informed developers and support implementation efforts around the world. We plan to support the development of interoperability global goods like the content, like the implementation guide, profiles, the white papers we've referenced, the software like Gazelle, the cloud-based test infrastructures and developer sandboxes that we're putting together, and services like the Connect-a-thon, like this global health track and other educational events, projectathons. There's a session about that on demand as well if you have the opportunity to look at that. But specifically, we're going to be also promoting the testing of the International Patient Summary and recruiting more participants in that effort. Finally, so the track description for this in our agenda contains some links to other reference materials like the white papers we mentioned. Please take some time to review that and join us in some of the future sessions we have at the Connectathon this week. Most of the content is designed as on demand, so it'll be available for at least 60 days after the event. Even the live sessions will be recorded and replayable. And as we mentioned, there's an office hours session on Thursday at 9 a.m. Eastern. We changed it and moved it back an hour. And that'll be facilitated by John Murky, who's the co-chair of the IHE ITI Infrastructure Committee, and a couple other IHE SMEs. And they'll be there to help answer any of the questions folks might have. And with that, I'd like to move to our conclusion.
Oh, wait, I made you promise. You need to give me my two things that I want to call out.
Go for it, Derek. I was going to say, now we're moving it to Derek anyway.
Oh,
so
you were? Okay, I'm sorry. So to sort of pull on two threads that Amit introduced there. One of them, we had an opportunity last January to have our last face-to-face Connectathon that has been had by IHE since the pandemic. At that Connectathon, we had an opportunity to have some teams come together and demonstrate a project that is a joint project. Again, a lot of collaboration going on between HL7 and IHE around computable care guidelines. And we were able to show some of that. That work is being led by WHO. They refer to them as smart guidelines, so they've done better branding than we do on our CCG moniker in the Quality Research and Public Health Technical Committee, where that work is being done in IHE, and then the CPG on Fire community that work is in parallel being done in HL7. I say that because some of the teammates that did that demo a year ago are in fact the same group of teammates that WHO has since tapped to develop an immunization smart guideline. That immunization smart guideline work was launched to support routine immunization, of course, which is being done everywhere, but also to look at COVID-19. An aspect of that work is the smart vaccination certificate, again being led by WHO. And one of the things that WHO is keen to be able to leverage is some way to have this global specification to be published in the coming weeks conformance testable, because there's 190 countries are going to have to stand it up. And I don't want it to be lost on anyone what Amit was talking about. The notion that this platform, this global track, this global health track with a reference implementation is going to be available at this Connectathon, and then at the HL7 Fire Connectathon, and then at the IHE European Connectathon. This idea that a conformance testing or a reference implementation can be used for sandboxing to help development and for conformance testing as an instrument of governance in the hands of countries that need to have interoperable digital health infrastructure in their countries. This is a really powerful thing. This kind of collaboration is really important. And the fact that this is an OpenHIE on Fire reference implementation means that right away, the dozens of countries that have already named OpenHIE as their national reference implementation, this is something that helps them. This is something that can be used by them. And this is a really, in my view, a big step to be taken by this new consortium. This kind of collaboration is what the OpenHIE initiative has always been about. This kind of collaboration is what IHE and HL7 and HIMSS are about. And it's all coming together. And with that, I think we get to hand back to Jan. And I believe that Jan is going to have, she's going to draw in a colleague, mutual friend, to take us home. Take us home, Jan.
Yeah, give me 1 second here and I'll restart my video because I've been not in the limelight for a few minutes. And then I'm going to give us a feel-good slide to take away here. Yeah, so, you know, everybody's heard so much today, and a lot of our conversations have been about context and the challenges and the limitations and things we're trying to overcome. And a lot of our talk, we're all geeks here, so we're really excited about the technology, and we've kind of dove into like, what does it take? We saw the clear box of going through the kind of the code moving through things and information flows. But just to remind everybody here, like, the truth is technology isn't the focus. Standards aren't the focus, right? The people actually are the focus. And going back to our patient journeys and really thinking about like, why are we doing this? It's because of the people, right? And often we get into the mindset of like, oh, we're really focused on a patient at a clinic. But the truth is we're focused on the population at large, and that includes us, right? And our families. And how do we take care of people with the information that we can get in front of a doctor, right? So our job is not the technology, it's how the data is used. And standards and guidelines and the technologies that are implemented using those are a way to get that data available to the right person, the right time, in the right format, for that right decision for that patient and person in front of them. And so when we think about how do we come together and the impact we can make, like there's a African proverb, a lot of people in global health know this. I don't know if it's a real proverb or it's just something that people see on the Johannesburg airport wall, but it says, you know, if you want to go fast, you go it alone. If you want to go further, you do it together. And the truth is, I actually think we can go fast and further together. And it's not one or the other. And what I've seen proven over and over again is when communities come together like OpenMRS and OpenHIE, and the emergence of like OpenCR, when these communities of people around the world come together, it just makes a huge impact. And places like Haiti and Kenya and Rwanda and Mozambique all start really moving towards these systems and this thinking around how information flows and is used that really do improve the lives of the people living in those countries. And so with that, I will let my friend and colleague, Paul, introduce himself and say a few words as well. Paul?
Yeah, hi. Good morning, good afternoon to everyone. It's nice to see a number of friendly faces in the audience, and also greetings to all of the hardworking members of IHE. I've been fortunate to work in the global health industry for a couple of decades now, and I wear one hat as a faculty member at Regan Street Institute, but I also lead OpenHIE. It looks like I'm being asked to put my video on. Let me see if I can do this real quick. I don't have a fancy IHE background, but here I am. You know, it's been wonderful to be a part of this session for a few reasons. One, because I think at some level, everyone within IHE deserves an opportunity to understand the impact of their work globally. And hopefully you all have been able to see in a really concrete way ways in which some of the good work that IHE has been doing over the years is being leveraged and packaged into ways that are directly meaningful to underserved environments throughout the world. But maybe in closing, I also want to make another observation to you. I don't think that my colleagues from Kenya who are on the phone and on this call, along with colleagues from other environments throughout Africa, are looking for charity. These are very bright, exceptionally talented, hardworking individuals who understand that they have an opportunity to implement digital health systems perhaps in a different way than we have in places like the United States. In fact, what I often say to my colleagues is that if you want to learn how to do information exchange incorrectly, you look at the United States as an example of all of the things to not do correctly, how to do it wrong. And I think that in some ways, the global health community consists of a number of focus areas and countries where they're looking to implement these systems differently. And so they're not looking for charity. What they're looking for is solidarity. And the difference between charity and solidarity from my perspective is that in charity, there's this assumption that those that have are giving to those who don't. And the concept of solidarity, we all have something to give to each other. And I think that collaboration with the global health industry provides a really important opportunity for solidarity. And that I think IHE has just as much to learn from environments like Kenya and others throughout the global health industry than the countries have to learn from organizations that have historically worked from IHE. Constraint and frugal innovation often breeds efficiency. And I think now more than ever, as IHE and other standards-based organizations are looking to sustain themselves, and more importantly, looking to implement and see their work being implemented broadly, that there's just as much opportunity for IHE to listen to organizations and countries like Kenya as there is opportunities for Kenyans to listen to organizations like IHE. And so from my vantage point, I think implicit in this opportunity, I think all global health practitioners believe that we learn just as much from those environments as we might bring to them. And so I'm hoping that as we look forward to this opportunity for collaboration, we're thinking really carefully about what that means and what solidarity and partnership actually means, and how we can give voice to the wisdom within a context like Kenya. Because it's not as if they're incapable of doing it. I think they're just working within a different set of constraints and a different set of opportunities. So I leave you all with that. And I just want to again reiterate our deep appreciation to IHE for creating a forum for this kind of conversation. And communities that I've had a part of, such as OpenMRS and OpenHIE, I think have a real opportunity to collaborate with standards bodies like IHE in a real substantive way. Thanks.
Thanks, Paul. And with that, I will hand it back to Amit and Derek to close it out.
Thank you so much, Paul. Thank you, Jan. Thank you, everyone who contributed and participated today. Paul, you left us with a great message, and thank you for kind of closing it out and bringing us home. Because yes, it's not about charity, and I love it. It is about solidarity. I feel like this is an exchange, and it's about mutual support. I think folks in the US will be the first to say, we have not figured it out. And I'm not sure anybody has yet. And so through the course of putting this event together, I learned a lot. I learned a lot every day. And I look forward to learning more with the community. And so once again, thank you all for your participation. Thank you for your contributions. And I'm looking forward to working with you in the future. There are a couple more live sessions. Today is our global health track. Tomorrow is our local health track, which is highlighting a couple efforts like the CDC's MedMorph project, making EHR data more available for public health. That sounds interesting. And then there's also the SANER pilot project, which is about situational awareness in the novel epidemic and its response. On Thursday, there's sessions around Code for Health, which is around open source software libraries that are designed to be developed for plug and play IoT devices. So I hope you can join some of those sessions. And if not, the material will be available for at least 60 days on our platform.
If I can, just because you're not going to thank yourself, Amit, can I use this as an opportunity to thank you and all of the people on the team at HIMSS and IHE USA that helped put this event on. I also want to especially thank you for being completely receptive when Jan and I said that we should have a no barriers way for people to come and participate in this. And you stepped up, man, and I completely appreciate that. I also want to,
Plus one. That's amazing.
So
thank you.
Also to the whole planning crew for this this particular session. I'd stand shoulder to shoulder with you guys any day. What a terrific group of teammates. I also just want to do a special shout out to Paul. Paul, again, he doesn't say it himself, but he is a founder, one of the first of us that started this whole OpenHIE initiative, and was receptive at the outset that a global public good focused on interoperable digital health sharing should be standards based. We found that there were some gaps that needed to be filled. And one of the things that OpenHIE did, and that Paul was supportive at the outset, and again, was able to leverage some of his ability to get funding for these things. He was able to help there be OpenHIE participants on the IHE technical committees, and that's been true for 7 or 8 years now. And there are a whole raft of IHE profiles that were authored by OpenHIE members that were filling in little gaps where some of the existing specifications that we had needed to take into account the low resource settings that we found ourselves working in. So this collaboration has been a fruitful one. The idea that this technical work that we've been participating in for some years now is going to get elevated, and that these platform capabilities are now going to be brought to the global health community. I think that's awesome. And Amit, again, a shout out for the leadership that you and your team have shown on that, and nothing but good days to come. The idea that this platform now moves from event to event and session to session, that gives us a way to really collect a community of practice around sandbox and testing implementations, reference implementations as a global public good. Man, that's a game changer. So Amit, thanks. You're way too kind to put yourself forward for that, but that is a big deal. And thank you so much for making some of this happen, and being a part of the crew that's seeing this global consortium come together too. I don't think you told anybody you're one of the board members on that. Good for you.
I'm blushing. I don't know if you can tell, but that said, again, thank you all for participating. And really, I can't take credit for it, because none of this would have been possible without my team. So thank you, Emily. Thank you, Sarah. Thank you, Adam. Thank you, Joyce, for making the vision a reality. So really appreciate it. And this is just the beginning. So look forward to more, and look forward to working with all of you. Thank you once again.